I am Dr. Priyanka, working as an assistant professor in Department of Pharmacology, School of Allied Health Sciences, Vinayaka Missions Research Foundation-DU University, Salem. Today I am going to discuss about antifungal drugs. In this session, we are going to discuss about introduction of antifungal drugs, classification of individual group of antifungal drugs, mechanism of action, and recent advances in topical antifungal drugs. So coming to introduction, what is fungal infection? Fungal infection mostly known as mycosis, and it is mostly eukaryotic, and the cell wall is rigid, made up of chitin 1,3 beta glucan, and the cell membrane is made up of ergosterol. Actually, it is not susceptible to usual antimicrobial group of drugs. So coming to individual classification, the first group of drugs are antibiotics. Polyene antibiotics, amphotericin B, nystatin, amycin and natamycin. Coming to heterocyclic benzofuran, that is griseofulvin. Coming to echinocandins, that is caspofungin, micafungin, anidulafungin. Coming to next antimetabolite flucytosine. Moving on to azole group of antifungal drugs, that is imidazole. These are topically used antifungal drugs: clotrimazole, ecanazole, micanazole and oxyconazole. Coming to systemic, it can be used both orally and systemically, that is ketoconazole. Coming to triazoles, it is effective in systemically: fluconazole, itraconazole, voriconazole and the newer drug posaconazole. Coming to allylamine, terbinafine, buprenorphine, naftifine. Other topical agents such as tolnaftate, cyclopyroxolamine, buprenorphine, anti-silenic acid and benzoic acid. So moving on to mechanism of action, squalene is converted to lanosterol with the help of squalene epoxide, and finally it is converted to ergosterol with the help of 1,14 alpha methylase. Finally, it causes lysis of cell wall. So coming to first group of drugs, polyene antibiotics, amphotericin B. It is a prototype drug of polyene antibiotics. So the mechanism of action of amphotericin B, it goes and binds with ergosterol, and finally it forms a pores in the cell membrane. This pores causes leakage of intracellular ions and macromolecules, finally leading to the cell death of fungus. So coming to the pharmacokinetics, actually it is not absorbed orally. In this condition, you can give IV. It can be made with the help of deoxycholate. So it is also given again orally, intrathecally, topically. When you are giving intrathecally, it can cause CNS toxicity. So again it binds to sterols in tissues and to lipoproteins in plasma. So it stays in the body for long periods. So in that condition, it is having a long plasma TF of 15 days. So moving on to uses. It is a gold standard drug for all type of systemic mycosis. Because of high toxicity, the use is reserved to only leishmaniasis, Kala Azar and some topical infections also. And it is used in immunocompromised patients also because it increases the immune status of patients. Coming to adverse drug reaction, it causes acute reaction. Acute reactions such as headache, chills, fever. Sometimes it causes severe reaction. In that condition, you can give injection hydrocortisone, very important injection hydrocortisone, 0.6 milligram per kg combined with amphotericin B reduces the intensity of this acute reaction. So long-term toxicity leads to nephrotoxicity. Nephrotoxicity causes reduces GFR, azotemia, hypokalemia also. In that condition, you cannot give concurrently with other nephrotoxic drugs such as vancomycin, aminoglycoside antibiotics such as ampicillin, gentamicin. So you should not give with amphotericin B. So next is anemia due to depression of bone marrow depression. It causes anemia. As I said earlier, it causes CNS toxicity when you are given intrathecally. So coming to newer formulation, this is very important. Why we need newer formulation? The only advantage we need newer formulation is it causes low nephrotoxicity. Low nephrotoxicity, obviously it causes minimal anemia, very minimal anemia, and it targets particularly to the reticuloendothelial cells. Those new formulations are amphotericin B, lipid complex, amphotericin B, colloidal dispersion, and finally liposomal amphotericin B. This liposomal amphotericin B is very important, especially in mucormycosis in COVID-19 patients. So coming to nystatin, it is again very similar to amphotericin B. Again it is having high systemic toxicity. So because of high systemic toxicity, it is especially used topically in superficial candidiasis infection. Orally again it is not absorbed but can be given in monilial diarrhea. So side effects is very minimal, but it is having high systemic toxicity. So side effects include nausea and sometimes it causes bad taste. Coming to echinocandins. Echinocandins are caspofungin, micafungin and anidula fungin. So coming to mechanism, it inhibits the synthesis, especially in fungal cell wall. As I said earlier, it inhibits the synthesis of 1,3 beta glucan. Finally, it causes lysis of fungal cell wall. Route, it can be given intravenously. When you are giving intravenously, you should keep in mind the patient is very safe or not. So when you are giving intravenously, rarely it causes thrombophlebitis of your injected vein. And finally, headache, rashes and flushing occurs in some patients. Used in aspergillus infection and candidiasis. Coming to heterocyclic benzofuran. Heterocyclic benzofuran, this group of drugs are griseofulvin. Griseofulvin, actually it is obtained from Penicillium griseofulvin. It is again fungistatic. Because fungistatic, it uses limited to certain group of fungus. It is active against dermatophytosis, trichophyton, microsporum and epidermophyton. Actually, it is having different mechanism of action. It interferes with mitosis and results in multinucleated and stunted fungal hyphae. Moving on to pharmacokinetics, it is having low water solubility. It is very least soluble in water. As I said earlier, it is fungistatic, only limited to certain group of fungus. Used in dermatophytosis, it has to be given 3 to 4 times daily. It should take with meals. Meals only you have to take this group of drugs. Duration, again its duration depends upon the site of action. Coming to the adverse effects, it causes low toxicity, headache and sometimes it causes GI disturbances. When you are giving long term griseofulvin, it causes transient leukopenia and albuminuria. Moving on to flucytosin, it resembles a synergistic action with amphotericin B. Because it develops rapid development of tolerance, it is a drug of choice for only few group of fungus such as Cryptococcus and Chromoblastomycosis. So it is having serious adverse effects such as bone marrow depression, finally causes anemia, bone marrow depression, and finally liver dysfunction is very serious adverse effects. This flucytosin is a pyrimidine anti-metabolite. It is inactive as such. After taken into fungal cells, it is converted into flyfluorouracil and then to flyfluorodeoxyuridylic acid. And it is an inhibitor of thymidylate synthesis. Coming to imidazoles and triazoles, it is the most extensively used antifungal drugs because it is having broad spectrum antifungal activity. It is having the mechanism of action. It inhibits cytochrome P450 lanosterol 14 demethylase enzyme. It leads to impairment of ergosterol synthesis. Finally leads to membrane abnormality in fungus. The first prototype group of triazoles is clotrimazole. Clotrimazole is effective only topically and it cannot be given systemically. So topically it can be given in vaginitis. It is a favored drug for vaginitis. It resembles long-term residual effect, especially in vaginitis infection. You can given once daily application. It is generally well tolerated. When you are using long-term, it causes stinging and burning sensation, especially in few individuals and not to all. Coming to ecanozole, it is again similar to clotrimazole. It is effective in some group of drugs such as dermatophytosis, otomycosis and oral thrush or candidiasis. Coming to miconazole. Miconazole, it is again effective only topically and it cannot be given systemically. It is efficacious drug especially in pityriasis versicolor, cutaneous and vulvovaginal candidiasis. It is having good penetration power, so you can use topically in those cases. Side effects include when you are having long-term application of miconazole, it causes vaginal irritation, especially in few groups. Coming to oxyconazole, it is again topically newer imidazole. It is recently introduced group of drugs. It is effective in some group of fungus such as tinea infection, dermatophytotic infection and vaginal candidiasis. It rarely causes local irritation. Ketoconazole, it is a first azole which is effective both systemic and topically. So it is having broad spectrum antifungal activity. It is effective in dermatophytosis, deep mycosis. Keep in mind, gastric acidity is very important for absorption of ketoconazole. Gastric acidity. So when you are having gastric acidity, you should, when patient is receiving H2 blockers, proton pump inhibitors, it causes neutralization of acidity. So in that cases, ketoconazole absorption will decreases. So gastric acidity is very important for absorption of ketoconazole. It can be given once daily, 200 mg once daily is necessary. Coming to interactions, it decreases androgen production and displaces testosterone from protein binding sites. So patients will have, especially men will have loss of libido, impotence, oligozoospermia, and in women it causes menstrual irregularities due to suppression of estradiol synthesis. So what advice you can give to patients? So when you are taken concurrently with other drugs such as H2 blockers, proton pump inhibitors, it will decreases the absorption of ketoconazole. So drugs such as phenytoin, rifampin, it induces metabolism of ketoconazole and it eliminates faster, induces a metabolism and reduces the efficacy of ketoconazole. And ketoconazole itself is a enzyme inhibitor. Keep in mind, ketoconazole is a enzyme inhibitor. It inhibits several cytochrome P450 enzymes and raises the blood levels of drugs such as statins, rosuvastatin, atorvastatins, those statins, next sulfonylureas, omeprazole group of drugs, and phenytoin also, it decreases the blood levels of those drugs because it is an enzyme inhibitor. Very important point, it is an enzyme inhibitor. So coming to adverse effects, as I said earlier, it decreases androgen production and displaces testosterone from protein binding sites. So it is contraindicated in pregnant and nourishing women. So mild side effects like nausea, headache, rashes, sometimes it causes hair loss. Because of this so many adverse effects, it is limited use in dermatophytosis. So you can use it as like shampoo, lotion, especially in seborrhea of scalp. In that condition, ketoconazole is effective. So next uses is Cushing syndrome. So it is effective in Cushing syndrome because it decreases corticosteroid production. Coming to next azole group of drugs, fluconazole. It is a water soluble triazole. It is effective both orally and topically. It is having wide range of activity when compared with ketoconazole. Its oral bioavailability is not affected by food or gastric pH. So you can take with other drugs such as omeprazole, neutralization of antacid, you can take easily. So it is a preferred drug, especially in fungal meningitis. Keep in mind fungal meningitis because it penetrates into brain and CSF. So in that cases, you can prefer drug as fluconazole. It is effective in fungal meningitis. The azole group of drugs effective in fungal meningitis is fluconazole. It does not inhibit steroid synthesis in man. So it is not steroid synthesis. It does not inhibit. So you can give to men and women. So adverse drug reactions. It causes less GIT symptoms. So it rarely causes elevation of hepatic transaminase, especially in AIDS patients. Coming to interactions, it is having less drug interaction profile. As I said earlier, proton pump inhibitors and H2 blockers will not affect absorption of this fluconazole drugs. It is used in Candida esophagitis. In Candida esophagitis, you can take 100 mg per day. Next uses pityriasis versicolor. This picture shows pityriasis versicolor and cutaneous candidiasis. In that cases, you should take 150 mg weekly per 4 weeks you have to take. It is also used in candidemia and fungal keratitis. In fungal keratitis, we can take it as eye drops. Coming to itraconazole. Itraconazole is having a broad spectrum of activity. Actually, in 200 mg, it is generally well tolerated. But for more than 400 mg, it is poorly tolerated. Again, its oral bioavailability is enhanced by food or gastric pH is necessary for absorption of itraconazole. So, this proton pump inhibitors, antacids will decreases the absorption of itraconazole. It is metabolized mostly in liver by cytochrome P3A4. Adverse reactions include headache, it causes hypokalemia and dizziness. It is the preferred azole especially for paracoccydiomycosis. It is a preferred drug. It is a drug of choice for chromomycosis. So, drug of choice for chromomycosis is itraconazole. MCQ question. Coming to voriconazole. Voriconazole is a second generation broad spectrum triazole. It is effective against certain group of fungus such as histoplasmosis, blastomycosis, and it is again a drug of choice for invasive aspergillosis. It is MCQ question. Drug of choice for invasive aspergillosis is voriconazole. It is again an inhibitor of several cytochrome P450 enzymes. It is again an enzyme inhibitor. It raises the blood levels of several co-administered drugs such as statins, sulfonylureas, phenytoin, omeprazole, etc. So, keep in mind prolonged QTC. QTC prolongation occurs when you are taking voriconazole. It rarely causes visual disturbances, short-term visual disturbances, especially in few patients. So, name some azoles which causes QT prolongation. The drug of choice is voriconazole. The drug which causes QT prolongation, that azole group is voriconazole. So, moving on to posaconazole. This is a recently introduced triazole group of drugs. It is a potent broad spectrum. It is having potent broad spectrum antifungal activity. Keep in mind, it is a only azole effective in mucormycosis. Other antifungal drugs effective in mucormycosis, I said earlier, liposomal amphotericin B. Liposomal amphotericin B is the drug of choice for first line of drug of choice for mucormycosis. And oral therapy include posaconazole. This is recently introduced drug of choice. What is mucormycosis? It is a group of fungus caused by mucormycetes. It is actually non-contagious. It won't spread from one person to another person. It occurs especially in patients who are immunocompromised and who are affecting with other diseases. And highly risk people include diabetic ketoacidosis and who are receiving anti-cancer drugs. Those people are highly affected by mucormycosis. So, it is otherwise known as black fungus. So, in that cases, posaconazole is effective. Because of high cost and limited utility, it is used only in those situations such as aspergillosis and invasive candidiasis. Again, it is metabolized by cytochrome P2C19. Moving on to allylamine group of drugs. Keep in mind, allylamine group of drugs are fungicidal and not static. It is a fungicidal. So, first acetyl-CoA is converted to squalene and then to squalene is converted to squalene 2,3 oxide with the help of squalene epoxide or squalene monooxygenase. This allylamine group of drugs goes and blocks squalene monooxygenase and the conversion of lanosterol and then finally to ergosterol will not occur. Accumulation of squalene within the fungal cell wall is responsible for the fungicidal action. It is very important mechanism of action. So, first prototype drug of allylamine is terbinafine. It is used both orally and topically. It is active. Side effect causes only few side effects such as gastric upset, rashes and taste disturbances, especially in few patients. Again, it does not inhibit cytochrome P450. Keep in mind, it does not inhibit, it is not an enzyme inhibitor like azoles. It is not enzyme inhibitor. Topically, it is used in some situations such as tinea pedis, cruris and corporis. Locally, you can use it as topically like creams, like you can use terbinafine. Orally, it is used only in few fungal infections such as onychomycosis and tinea capitis. Moving on to topical antifungals. recently introduced topical antifungals. First group of drug is tolnaftate. Because it is having inferior in efficacy when compared with other azoles, it is used only in few situations such as tinea cruris and corporis. It is not effective in candidiasis because it is inferior in efficacy when compared to azole and other antifungal drugs. So it is reserved for only tinea cruris and corporis because it is poorly penetrated into skin and it provides poor symptomatic relief. So you cannot use in other candidiasis and other infections. Sometimes it causes, when you are using long term, it can cause local irritation. It can be given sometimes with salicylic acid. So coming to cycloperox olamin, it is again used topically. It penetrates superficial layers. So you cannot give in systemic, you can use only topically. Systemic absorption is negligible. Only in few fungus, especially in tinea infections, pityriasis versicolor, dermal and vaginal candidiasis, and finally onychomycosis. Moving on to buprenorphine. Buprenorphine, it is a container of terbinafine. It is used only topically in dermatophytosis. You cannot use other types of fungal infection. It is reserved for use only in dermatophytosis. So coming to antisilenic acid, it is fungistatic. So only group of antifungal drugs which is fungicidal is terbinafine. Keep in mind, terbinafine is your MCQ question. Other than that, everything is fungistatic. It is again inferior to other drugs. When you compare with other drugs, it is inferior in efficacy. So it is reserved for tinea pedis and cruris. Again, it causes irritation and sensitization, especially in few individuals. So moving on to benzoic acid. Benzoic acid is very important. It is having both antifungal and antibacterial activity. It is better absorbed, especially in acidic medium. It is absorbed only in acidic medium, better absorption. So it is having prolonged treatment required because it is absorbed in acidic medium. You can need prolonged treatment. You can use it as Whitefield ointment. Whitefield ointment we are using daily, like in the food, like Whitefield ointment. So benzoic acid, in this Whitefield ointment, the composition is benzoic acid 5% plus salicylic acid 3%. It again causes irritation when you are using. Too much of anything is good for nothing. When you are using long term, everything. So weekly treatment, 4-week treatment is fungal. But more than that, when you are using now, so you can cause irritation. This antifungal drugs will cause irritation, burning sensation and everything. Thank you for listening my class patiently. Thank you.